right, welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I am joined by Dr. Haywan Chiu. Thanks for joining me.
Hey, Jeff. Thanks for having me. It's a pleasure to be here.
Absolutely. We were talking a little bit before we went live, the difference in the temperatures of where we are right now. I'm in Iowa, and you're out in the desert and enjoying some bright sunshine. How is it out there?
Oh, Albuquerque's great. You get 4 seasons, but it doesn't snow doesn't stick. It doesn't get all yucky, and we do get snow days. Schools cancel for like a couple inches.
Yeah.
It's a pretty mild weather, all things considering. Not much wind. That I'm used to cold wind from San Francisco in the Bay Area, where it's foggy all the time. The wind here it's there, but it's not like so chilly.
And you did school in Philadelphia, and that they get cold there too.
Yeah, that's some chilly wind there.
Yeah.
The climate is perfect for me here in Albuquerque.
Absolutely. So what drew you back to kind of the Southwest? You're from California and then did school out Temple and then back to California, but what drew you to New Mexico?
Yeah, I had no idea anything about New Mexico until my 3rd year in residency, where I was trying to figure out jobs, and I made some connections during my year prior, and there was a guy in New Mexico who was looking for someone to help with limb salvage. I interviewed and did some research about New Mexico. I spent a few days there, and felt like it was a good fit. And it was like, well, what? How bad can it be to just try it out a place? At the time, I didn't have kids. I had my wife at the time, and she was open to going to checking out a different state to practice. So that's how we ended up there.
So, speaking of Philadelphia, you're an Eagles fan, aren't you?
Oh, yep. I became an Eagles fan since I went to podiatry school at the end of it.
Yeah.
And I grew to actually watch the sport of football through watching the Eagles. So It's been a good past few years for Eagles fans.
Yeah, for sure, especially this year with the Super Bowl win. And my boy Cooper DeJean from Iowa came through with a big pick 6 there. So.
Oh, my God. That was insane.
Yeah, that was awesome.
Yeah.
It turned into not even a very interesting game after a while. It kind of started to somehow feel bad for the Chiefs, even though they're back-to-back champions. It's getting ugly.
I didn't feel bad. I loved every minute of that game.
I'm sure you did. You, along with all the other ruthless Philly fans, they're like loving every second of it, I'm sure. So,
man.
I bet that was fun.
It was so much fun. Yeah, they actually broke the record for merchandise sold in the first 24 hours after the game.
Oh, that's awesome.
Yeah, I helped contribute.
Philly fans, I bet. Those Philly fans are nuts, man. They're like, woof.
Yeah. I'm not a typical Philly fan. I'm not climbing the poles and setting things on fire.
Seriously, they're nuts. Yeah. They love it.
I wish I was in podiatry school right now just for the Super Bowl celebration.
Oh, I bet. Yeah, it looked pretty wild.
Yeah.
Looks pretty wild there. So let's talk for a minute about the residency that you guys have down going in the Albuquerque area right now. Why don't you talk a little bit about the residency and who they work with and what that's all about?
Yeah, so there's a New Mexico VA podiatry program here. In the state of New Mexico, there's only one residency program. So these residents have access to all the attendings. It's kind of like a free-for-all, all-you-can-eat buffet of cases. Mm-hmm. The climate, the kind of podiatry ortho climate here is really in our favor. There's not a ton of ortho docs that have interest in doing ankles. And so when we're on call, we get trauma call too. Mm-hmm. Although it's not a level 1 trauma center where we're at in the main hospital. So we don't get a ton of pelons or high energy stuff that goes to the university where they're like their own little bubble.
Yeah.
But yeah, if ortho gets a ankle trauma consult at our hospital, they'll say consult podiatry. So we get all of that, and our scope of practice is really good. So
nice.
There's.
Plus, I was gonna say, if you do enough pelons, you don't want those anyways. Like those things are just nightmares. Just like you do everything but pelons. Like, all right, I'll sign up for that right now.
Yeah, I haven't trained in a ton of high energy trauma, so like very simple pelons, I'll do it. But anything that's more intense, I'll throw on the delta and refer to my colleagues who will do it.
Yeah, for sure. So the residents work with you then, and your main interest lies in diabetic salvage, limb reconstructive type things, but they rotate through with you as well?
They do. They scrub most of my cases, um, and there. I mean, I get that they can only be available certain times, and some months there's less accessibility than others for the residents to go out and scrub cases. So some of my cases go uncovered, but yeah, I get it. That's how programs work. They pick where they can to get the most educational value for themselves. But
Sure,
yeah,
that's kind
a
of
ton of
nice.
my cases get covered, and I have sometimes I have bigger cases. Like if there's X fixes, I invite two residents just because there's plenty of work to do for
Sure.
more than two set of hands.
Yeah, for sure. Shout out to my buddy Mo, who's a first year resident there and rotated through with me. So I'm sure Mo's listening. Shout out to Mo. And then my previous co resident is the director there, Sarah Malise. So shout out to them and keep up the great work. It seems like a really good program you guys have going there.
Yeah, Dr. Mali is good with the academics, and she encourages people to scrub and get those cases. So I think she's doing great things for the program here. She's a
Good.
great resource for them.
Great. So for anyone who hasn't been to Albuquerque before, what would you tell any prospective students who might be interested in coming to spend some time there? How would you describe the area and what it's like?
I would say it's like a small town feel. Like when I first visited, I checked out the main places that most people would call like the inner part of the city or the most hustling and bustling places, and it felt like I'm used to San Francisco, or I've been to big cities like New York and Philly, and it's
Hmm.
definitely not a big city. If you're looking for a small city, kind of slower pace of life, that
Hmm.
would be Albuquerque,
Yeah.
which I appreciate because like I'm used to that very hustling type lifestyle. Growing up in San Francisco and spending time in Philly,
Hmm.
and I think personally, like having that a little bit more level of chill is good for my mental health
Yeah.
because constantly going all the time it can be difficult, and it can induce anxiety and stress and lead to burnout and such. So
Hmm.
having a small town feel that I live in has been good for me.
Hmm.
And the weather, we get all four seasons here in Albuquerque, which is nice because sometimes it'll snow but it doesn't stick, so you
Yeah.
still get to enjoy some of the snow all four seasons,
Yeah.
which
Absolutely. And I've heard
yeah.
awesome things about Santa Fe. Never been, but we were talking off the air. I'm headed to Albuquerque and Santa Fe in a couple of months, so I'll be out there to check it out. But I've heard great things about Santa Fe as well.
Yeah, it's described as like a rich artsy area, a lot of good food, a lot of artists go there, a good place to go for inspiration or just enjoy the food scene.
Hmm. I'm excited.
Yeah.
That's all I really care about when I go on vacation is where can I eat? How much can I eat?
Hmm.
When's the next time I can eat?
Yeah, there's a restaurant we like to go. It's called Clafoutis. It's like a French Canadian restaurant.
Uh-huh.
Really, really good food, consistent, and
Hmm.
good pastries. So
Nice.
if you're into that,
Check it.
that's a good
I'm into
spot.
everything. I'll eat anything.
Nice. Yeah, they
If
got
it's
some like Michelin star restaurants there too that I haven't been to, but one day
nice.
I will. Yeah.
Yeah, for sure. All right, so let's talk a little bit about the diabetic reconstructive nature of your practice because that's a very complicated thing in a complicated subset of patients. You know, the patient who
Hmm.
gets a diabetic foot infection, we can all picture this patient. They're complicated medically, they're metabolically inhibited based on all their other comorbidities, and it makes it difficult to heal. Even if you do all the correct things, it's still a complicated patient to heal. So let's say you have a patient that comes into the ER and the ER calls you and says, "Hey, we have this diabetic foot infection." I have a lot of younger listeners. What are some of the first parameters that you're thinking about when you approach all of these patients in terms of what labs do you want? What are you looking for? What determines, okay, we got to go right now or not? Like, what are some of the initial things you're thinking about?
Yeah, I think the most important thing for me would actually be a clinical photo. That gives me the most amount of information out of all the advanced imaging, x-rays, labs, and such.
Mm-hmm.
The photo tells me, kind of puts me in the ballpark of how I need to respond.
Sure.
'Cause sometimes you can have wet gangrene in someone who's not septic with no white count. you could have gangrene and you get MRI and the bone marrow's normal with no bone edema.
Hmm.
You could have neck fascia and you get an X-ray and there's no like soft tissue emphysema. So the most useful piece of information would be a clinical photo.
Sure.
And then from there, everything else just kind of helps support the clinical photo. But based on that information, I can quickly decide if, hey, I need a round right now, or I can round after clinic, or I can maybe round tomorrow when I'm already there for cases.
Hmm.
And then after that, it's, there's a lot of other factors that go into decision making.
So, what labs do you absolutely need to know? White cell count, procalcitonin? Do you put much stock into CRP or SED rate, or do you assume they're going to be elevated and who really cares, or do you care? So, what are
Yeah.
the labs that you really focus on?
It would be white count and hemoglobin.
Hmm.
Those are the two more, I mean, I guess our CBC. That's the most important one for me.
Yeah,
And then your basic metabolic panel, just to make sure there is anything that's contraindicating surgery or general anesthesia. But those are the two main things that I care about. ESR, CRP are non-specific inflammatory markers that I don't find useful at all unless you're
right.
monitoring something in the outpatient setting.
I
But
agree
even
with you.
then, like I still have questions of whether it's useful.
Yeah, I agree with you completely. The other thing that I
Yeah.
have a lot of question about, and maybe you do, maybe you don't, so I shouldn't have led you that way, but what are your thoughts on getting an MRI in some of these patients? Does the MRI, it, well, I'll try not to guide you. What are your thoughts on MRI in some of these patients?
I honestly rarely get them.
Yeah,
I don't find MRI useful. If there's an abscess, you should be able to figure out where it is with clinical palpation, evaluation. The skin tells you everything you need to know.
right.
So I rarely get an MRI. Only time I get it is really unusual situations where I'm confused on where exactly the infection is, um, or like if there's a chronic bone infection going on where I just want to figure out the extent of the bone damage.
Sure.
But I don't use MRI to tell me where to cut. I don't use it to tell me what to amputate. Um, so yeah, I rarely use it.
Yeah, I agree with you. And I've worked at quite a few hospitals since residency, but the quick trigger response for most admitting physicians, if it gets admitted to medicine, would be they got to get an MRI, and they get this MRI, and they're like, okay, we got you an MRI, and I'm like, okay, I don't know what you want me to do with that information. It very rarely changes my approach. I'm either, like you said, clinically looking at the foot and saying like, all right, we got to go. That all needs to be debrided, or this needs to be amputated, or whatever it may be. But it very rarely changes my clinical course. So I think we overutilize MRI, and maybe that is more of a medicine thing versus a podiatry thing. But I don't find much value in MRIs at all. So I was interested to hear you say that, because maybe I thought I could have been missing something. No, you have to look for this or this, but I think we're overutilized, and they're not cheap too, and they don't, they take forever, and half the time I go round on a patient, they're off getting, they're getting an MRI. Why?
Mm-hmm.
God, I'm here to see him now. All those things. So interesting thought about the MRI.
Yeah, I don't know. I think it's just a overall medicine thing combined with podiatrists that don't do a ton of limb salvage, and that's how they were trained.
Right.
That's how traditionally internal medicine is taught. You get an MRI to diagnose osteomyelitis,
Mm-hmm.
and I mean it's so like how do you change that? All I can do is just teach my residents my way of thinking. I
Mm-hmm.
can explain my rationale, and
Mm-hmm.
I just that's all I got.
Right. What are things that you would see in the ED that would make you go to the OR right away? What is your, because a lot of times my thinking is this didn't start right. It didn't start 10 minutes ago. So I don't need to get in there 10 minutes from now. This has been going on for a long time. Now, if they're hemodynamically unstable, we all understand there are patients that we need to advance quicker. But what are the
Mhm.
indications for you to go to the OR, say in the middle of the night versus waiting till the next morning or next afternoon?
Uh, I don't operate in the middle of the night for anything, even if
Okay.
they're
I don't
septic,
either.
gas,
Well,
gangrene.
yeah.
and
And I
so,
agree with that. Yeah.
so like, let's say someone is. I've had patients that are intubated septic with gas gangrene to the hip
Mm-hmm.
that can survive a few days with antibiotics, and they get better.
Sure.
They can get medically stabilized with vasopressors, and I mean, but those are that's when you're operating in the middle of the night is a open BKA for someone who's so sick they're going to decompensate unless the leg comes off.
Mm-hmm.
That to me is when something needs to be going at night.
Right.
And I think that's due to the total volume of bacteria and infection in the area and the septic response to it.
Mm-hmm.
I think those are the situations that need emergent, like surgery in the middle of the night or cancel other people. But usually for podiatry cases, there's not enough of an infectious burden where the surgeries available to us are needed to do something in the middle of the night to save someone's life. A
Yeah.
lot of times they can be medically stabilized and they'll do better with the general anesthesia to do the foot portion like the next day or a couple days after.
Mm-hmm.
And I think we're taught to say, gas gangrene, emergency, bump everything, do surgery right away. And I think
Right.
is I don't think that's realistic.
I agree with you. What are your thoughts on initial antibiotic management transition to targeted antibiotic management based on cultures? Do you have some go-to broad spectrum antibiotics? Are you a vancomycin guy like the rest of the world and then targeted, or something else?
I was trained vancomycin or vancomycin. I think that's fine. Honestly, I don't really care. Whatever the hospice wants to do is fine.
Mm-hmm.
We can debate about what's the chance of this person having MRSA and needing vanc or versus just going with like a ceftriaxone or something
Right.
in isolation as your broad. I don't worry too much about that. Like I don't think it matters a whole lot. I just focus on my portion, which is the surgical source control.
Mm-hmm. And then what are your thoughts on initiation of antibiotics? Obviously, if we take cultures before initiation of the antibiotics, they say that they're more accurate, but I don't know that I 100% agree with that. I think it's more important to initiate IV antibiotics to stabilize this patient. Depends on the patient, the situation, and it's not like magically half of the different bacteria are going to disappear by the next day when
Mm-hmm.
I take the cultures. I've never really understood, like, well, wouldn't that be a good thing? Then I don't have to worry
Yeah.
about them. If they're not there, then wouldn't that be a good thing? I've already checked those off the list, and we just have to focus on the ones that are left behind. But what are your thoughts on antibiotic initiation timing versus cultures?
Yeah, I 100% agree with you. It seems silly to tell a patient we're going to not give you antibiotics so that we can get a good bacteria sample and let it keep infecting you during this meantime
Right.
so, so that we can know what to treat you with.
Right.
I'm like, no, just kill everything. If we can kill it
Yes.
all with antibiotics and get a negative culture, that's a good thing, right?
Yeah. Okay.
So I
Thank you.
think
I agree
that comes down
100%.
to yeah. So usually when I do a bone sample in surgery, I get a nasty, like an obviously infected piece of tissue, and that'll
Mm-hmm.
be my deep tissue sample for a culture, and then I'll get a clean margin, whether it be bone margin or soft tissue. But usually all I need is just that one deep tissue that's dirty.
Mm-hmm.
That's for sure going to have bacteria in there, and I would prefer the patient just to be treated on the antibiotics in the meantime before
Mm-hmm.
surgical intervention.
Yeah. And then you target it based on the culture
Yeah,
results
yeah.
to that. So I
Hmm.
want to talk a little bit about some research that you've done. I'll just read it. You know the name of it, but I'm going to read it for people who don't know. Percutaneous medial band plantar fasciotomy for treatment of chronic plantar hallux ulcers. Um, and so that's utilizing an 18 gauge needle to transect. Actually, I'm going to let you tell the people. So tell us what the research project is all about and what you're doing in there.
Yeah, so the Halix IPJ is biomechanically different from a wound at the tip of the toe.
Mm-hmm.
And so um, there's a few ways to reduce pressure to the Halix IPJ, and it all comes down to increasing flexibility at the metatarsal phalangeal joint. There's a few ways to do it, but traditionally, the Keller procedure is the most common way to offload it.
Right.
Although that's not a great procedure in someone who's in their 40s, who's labor intensive, who needs to go back to work in construction like 12-hour shifts.
Yeah. So we're
Although,
saying,
yeah,
sorry, that we have limited dorsiflexion of the hallux, which is leading to increased plantar pressure at the IPJ at the end of propulsion, right? And so if we can
correct. Yeah,
increase
hallux
the
limitus.
Right. If we can increase the dorsiflexion at the MPJ, we can offload some of the plantar pressures at the IPJ. I'm just trying to clarify that for some of the younger people.
Oh yeah, yeah. That's exactly right. And so traditional surgery would be to remove the head of the proximal phalanx, kind of like a regular uh, arthroplasty, which directly offloads the ulcer but does nothing to the MPJ. And I've had some ulcers recur even after hallux IPJ arthroplasties.
Mm-hmm.
And then the other option is a Keller, where you remove like a centimeter gap from the base of the proximal phalanx, and that detaches all the attachments to the great toe, and that makes it super flexible.
Mm-hmm.
But in someone who's a laborer, that may not be the best option because the toe can end up recontracting, developing arthritis, or kind of drift off into different directions.
Mm-hmm.
Um, so that's where I came up with the idea to look for alternatives, and that's when I was in residency when I found the article by the Kim et al. In JBJS. They talked about selective plantar fascia release,
Mm-hmm.
and they had some really cool pictures showing how they released just that specific slip to the toe. And I saw that, and I convinced my attendings to let me do it. And
Mm-hmm.
we did on a couple. The first one was a bilateral medial plantar fascia release at the instep on this patient, and it ended up helping and healing him.
Yeah.
And then the other time we tried it was when there was a patient with partial hallux already gone from a previous partial hallux amputation.
Hmm.
And it's like, well, partial hallux stumps that get an ulcer, what do you do with that? Like, if you do a Keller, that's basically amputating the rest of the toe.
Right.
So what have we got to lose? So we did releases for those situations too, and that's how I started to to incorporate that into my practice now.
Yeah, so let's talk about the technique for a minute and where people can read the article, but I find it interesting to hear it directly from someone who's done it quite a few times. Is what are you looking for, and what are your steps of how you're performing that?
Yeah, so anyone who's done a fair amount of flexor tendon releases with an 18 gauge needle is familiar with the feel, because
Mm-hmm.
it's a completely percutaneous technique where you're feeling everything. You can't see anything. So once you know how it feels to cut through structures with a needle, um, as you do more releases, the next evolution is to take it up a notch and cut the FHL tendon, which is bigger, and then after that you can cut the plantar fascia ligament. And the technique is, first of all, understanding that the plantar fascia is basically attached to the skin at that level, at the level of the arch.
Hmm.
It's very connected to the skin, so it feels like you're cutting dermis.
Hmm.
It feels kind of weird. It's not like at the level of the heel where you're cutting it deep.
Yeah.
This is right next to skin, and you can see the skin dimple as you cut it. So the technique is basically I go from medial to lateral, where you can feel the medial margin of the plantar fascia,
Mm-hmm.
and then you just go in and just kind of move it in the sagittal plane direction up and down. And I like to at each time you advance the needle, I go through under the derm, like just deep to the dermis, and you push the needle in towards the foot. And then I go around, go back in near the dermis, and push it into the foot. That way, if I'm going the opposite direction, I might lacerate it out the skin and
Sure.
puncture the skin with the needle,
Right.
which isn't the end of the world. And I mean, we could do it open too, but if you want to
Right.
try and do it completely percutaneous and leave a very small surgical footprint, that's how I do it.
And how much are you aiming? What's the width of the plantar fascia that you're aiming to transect?
I end up burying the whole needle in there.
Okay.
So I might even go near the second slip.
Mm-hmm.
It's hard to feel when you're all the way through,
Yeah.
because you don't get like a sudden release. Like with a lesser toe tenotomy, you get a sudden release, you're done.
Yeah.
When you're doing the plantar fascia, the only feedback you've got is palpating the dell.
Sure.
Once you're through transecting it, you can feel the dell, the defect, and then that's when you pretty much know you're done.
And your
I'll also,
level. Oh, go ahead.
yeah. And then the other trick is to insert the needle and just kind of move it up and down. And if you don't feel any snags along the way, then that's another way to tell that you're done.
Okay.
But when I dorsiflex the hallux, I honestly don't notice a difference before or after. I can
Okay.
only trust I've done enough, let them walk, and then they heal.
Sure. That's interesting. And the level is, I read 2 centimeters or so proximal to the tibial sesamoid. Is that kind of
Hmm.
the ideal level of where you're inserting the needle?
Correct. It's just roughly that's where you can most easily palpate it.
Hmm.
Because I'm looking to transect it at an area where I can easily palpate it and get that feedback to know that I've done the release.
How
That's
long
it.
does it typically take you to do that? Because I've done, flexor tenotomies, and depending on, the patient and how mobile their tissues are, it could take a little while to kind of transect the whole thing. How long is this process
Mm-hmm.
taking you?
From start to finish, probably 5 minutes.
Yeah.
You numb them up, prep it with chlor prep. I just put on some sterile gloves and get an 18 gauge and cut it.
Hmm.
I'll have a little bolt of sterile 4x4s to hold pressure. But the prep and the procedure takes the same amount of time as I do the prep. It maybe a couple minutes to do all the cutting and the palpation.
Hmm. And you've had really good outcomes with that, it sounded like.
It was okay. It's not like great. It's not perfect. There's
Uh-huh.
some failures, especially if I didn't select the right patient to try it on. But
So
it's
what
such a yeah.
I was gonna say, who is the right patient then? Who if anyone's listening and they're like, hey, I have a couple of those floating around, like what would be some patients who you definitely would want to try it on, or who would the patients be that you're like, I don't think that'll probably help?
Mhm. Yeah, for I know it'll for sure fail in those with a flat foot or Charcot foot where the arch is collapsed
Sure.
and you don't get that windlass mechanism. If
Right.
you can activate the windlass mechanism with dorsiflex and the hallux, and you see the arch reproduce, then you know that transecting the plantar fascia will have some effect on it.
Okay, that makes sense. And so is that one of your go-to procedures for, so I want to kind of spin it forward to people to try to get some practical knowledge of, we've all treated wounds in certain areas that are very difficult to heal. Is that one of your go-to procedures? I assume it is, of hallux IPJ wounds. And let's say if it, I already know the answer, it is, but let's move forward. If it's not going to be successful, like you said, a Charcot foot or a flat foot or something, what else are you thinking about doing for a hallux IPJ wound?
If there's a Charcot patient or flat foot and they have an IPJ wound, um, to me that's a killer.
Okay.
Even if they're young and they're somewhat active,
Yeah.
it's tough because like yeah, the keller is technically you don't want to do it on young active people,
Hmm.
but for in some cases like what option do we have?
Right. Especially when
So
there's Charcot and or limb salvage at this point, because
yeah,
any one wound can turn into any one infection that leads to amputation. So let's walk
yeah.
it back a little bit. Let's say you have a plantar first metatarsal head wound. What are your thoughts on? I read some of your stuff like peroneus longus release, or what are your thoughts? What are your go-to procedures for a plantar first metatarsal head?
Yeah, that's tough. That's of all the forefoot ulcers distal to the arch, that's the hardest one to offload for good reason. That's where we propulse. That's the biggest peak pressure. I'm still undecided. I think I used to do peroneus longus tenotomy in isolation,
Mm-hmm.
and I would say,
Where do you cut it?
oh,
Yeah.
just a retromalleolar groove behind the
Okay.
fibula.
Okay.
I do it in clinic, 2 centimeter incision, find the tendon, cut out a centimeter segment, throw it away, and suture them up. And I would
Interesting.
say I think it helps a little bit, but I don't do it by itself anymore because I've had enough failures, and I should probably publish on the failures just so other people don't, they can get the experience of like doing it in isolation for these.
Sure.
Um, but I would consider doing the PL tenotomy in combination with a TAL or gastroc if you don't want
Okay.
to mess with bones.
Mm-hmm.
I've toyed around with floating the first met, and I've had some success with it. I've had them also even I do it using a burr. The burr hole got infected before, where
Oh, geez.
I had to deal with like significant heterotopic ossification, and all this drainage made it difficult to heal even the burr hole.
Huh.
Um, but it's
Again,
possible to,
complicated patients, right?
yeah, exactly. Um, but I think the answer might be somewhere in a combination of procedures. I think
Sure.
PL tenotomy is an adjunct. I think TAL or gastroc and add in a first met osteotomy some way, somehow would be how I approach it nowadays.
Mm-hmm. Makes sense. So
Um,
for anyone listening, the peroneus longus is going to plantar flex the first ray. So if they have the plantar flex first ray, increase prominence under the first metatarsal head. We're releasing the peroneus longus to try to limit some of that plantar pressure. But you're saying that alone you haven't seen to be enough, and that maybe we need to do a posterior muscle group lengthening in addition to that to offload the forefoot pressures even further.
yeah. I mean, the Kim JBJS article that did the selective release, they also did it for first met head and second met head ulcers, where they released the fascia.
Hmm.
Um, it's kind of interesting how releasing the fascia could be a treatment for both hallux HPJ ulcers and first met head ulcers.
Hmm.
And I think like if there's a caveus foot type, I think releasing the plantar fascia makes sense for it. If it's a flat foot and they're propulsing and creating a wound at the first met head, I think that's a whole different animal.
Yeah.
I think they're just walking with an external rotated gait, and that's just the way they're propulsing. There's no way you can change that.
Right. Let's go one step further and do a heel wound. My least favorite thing maybe on planet Earth is a plantar heel wound. So what are your, I know it's going to be a combination. It's going to be completely variable based on the patient and all these factors, but let's say they have that direct plantar heel wound. Aside from offloading and things like that, do you find any procedures to be very successful in heel offloading?
No, nothing works for that.
Yeah.
Usually it's there because of Achilles ruptured or a ruptured TAL.
Mm-hmm.
If it's plantar, it means they're weight bearing and they're somehow just kind of pounding that heel, trying to shorten the Achilles tendon or fix a chronic rupture in a diabetic who's had a heel wound is asking for infection, and
Mm-hmm.
it rarely works. So it's usually it ends up being a vertical contour calcanectomy for me
Okay.
and a crow boot.
Sure. Forever.
Yeah,
Yeah.
yeah.
How often are you putting people into a crow boot after kind of a routine Charcot reconstruction? Because if you do Charcot reconstructions for long enough, it feels like it's just a ticking time bomb until something else seems to go haywire, whether it be the original surgery or an adjacent joint or whatever it may be. Do you keep your patients in crow boots after reconstruction forever, or do you let them try to get out of the boot? Or what are your thought processes on the role that a crow boot plays?
Yeah, back when I used to do more beaming of the whole foot and leaving the ankle joint alone, I would still keep them in a crow boot. I
Mm-hmm.
there's such a I mean it's so hard for you to get a completely solid fusion in the midfoot to where they can walk in a shoe. It's really difficult. So I do tend to keep them in a crow boot for at least a year after doing the surgery. If
Mm-hmm.
it's a tibio-talocalcaneal fusion, I think a brace and a regular shoe would be fine if I feel comfortable about their fusion. I'll sometimes get a CT scan at 6 months and evaluate the level of fusion. And if there's complete good bone consolidation throughout and hardware hasn't migrated, I'll put them into a shoe.
Mm-hmm.
Eh, I think at that point I'll be fine.
Sometimes that's all they want. They just want to get out of the boot, and you're like, all right,
Yeah.
well, let's see what happens. I know you don't want to be in this big clunky boot forever, but you also like your leg too. So there's pros and cons here.
Yeah. Yeah. I scare them into thinking that if it doesn't heal because they chose to be in the shoe, it's their fault.
Right. I mean, it at some point it is mostly based on health choices prior to any involvement that you have, right? Like
Yep.
sometimes they have diseases that they can't help, but sometimes it's just, poor health choices in a previous time.
Yeah.
Well, it seems like you do a lot of orthoplastics, rotational flaps, and if someone was interested in starting to do those, what is the best way for them to get that skill? Because their residency may or may not offer that skill. Fellowship, did you get that training, or did you just kind of help, you know, do a little this, do a little that, and in advance to doing more and more? Or how does that work for someone who's
Yeah.
interested in that?
Yeah, so I guess for the younger listeners, orthoplastics is the world of, I guess, flap surgery.
Mm-hmm.
I don't know how to define it. I'm not the. I've only entered this world recently.
Yeah.
I call it a world because it's such a different way of thinking,
Mm-hmm.
different way of dissecting.
Yeah.
approaching the soft tissues. But it's basically like the classic would be like a reverse sural flap. That's a orthoplastic procedure. I guess the ortho part comes where we're putting delta frames or X fixes to offload this flap.
Mm-hmm.
Um, and if you want to get into it, well, I guess how I got into it was that, I never had training in it. I didn't know about it. And I didn't do fellowship. So after spending 7 years in private practice, I've developed the skill set to where I can adopt a new procedure like that without
Mm-hmm.
too much trouble. So
Sure.
I went to a local workshop. Paragon flew me out to a workshop, and I learned from the podiatrist and the faculty at that workshop.
Mm-hmm.
They taught me the basic technique, read more about it, understood it. I asked my rep to ship me a leg in locally where I can do some of my own practice just to refine what I've learned at the lab. And then a week later, I was doing it on, on patients.
Yeah.
So
It's not that different than how we learn to do any new procedure that's out there. Is do a lab, do another lab, talk to a few people who've done it, get some tips, and
mhm.
then put it into practice. So, for
Yeah,
those who, yeah, go ahead.
it's kind of like doing total ankles. Like even if you have training in it, you probably don't want to do totals until you've had experience handling flat foot and caves foot recons and hindfoot fusions and such, where you've got kind of developed your basic skill set in practice and you've seen your skill sets improve before you actually start doing totals.
Mm-hmm.
Same with these flat procedures. You want to have your soft tissue stuff done. Yeah, you want to have your basics honed in before you start doing these.
Sure. So, for those who don't know, can you describe the process of a reverse sural flap and what's happening and why we're doing that?
Yeah, so typical wound would be like a heel wound where you have bone exposed and you want coverage. It's a large defect, and for some reason you don't want to do a vertical contour calcanectomy. Then a reversal flap could be an option. That means that and usually when we think reversal flap, we're specifically thinking about what's called a fasciocutaneous flap. Those terms mean you're including everything between the fascia and the skin. Cutaneous is skin.
Mm-hmm.
So the flap includes the deep fascia, the sural nerve, sural artery, sural vein, uh, the fat, and then the skin. You're creating this whole chunk. You're taking off this whole chunk and rotating it around to inset into the heel. And the whole flap is supplied by a peroneal artery behind just above the ankle. Typically 7 centimeters above the ankle is where that little perforator is supplying the whole flap.
Sure. So obviously, vascular evaluation prior to any
Mm-hmm.
flap reconstruction is paramount. So, what's your do you let vascular do an angio? Are you doing what are you doing to test the
Mm-hmm.
vasculature prior to flap?
Yeah, I usually I'll ask vascular to do a diagnostic angio, and I have a good enough relationship with them that they'll do it.
Mm-hmm.
Even if they're super busy, they'll figure out a day and time to do it because it won't take them that long
Sure.
if we know that they've got good patency. But even then, you'd be surprised what they find, and they may need to do some stents or some balloons to open things up for you.
Mm-hmm.
But you want to have that vascular evaluation, make sure your dominant arteries supplying that pedicle to your flap is all patent before you start cutting into it. Last thing you want to do is have this huge defect where it starts to necrose because you didn't do your due diligence.
Right. And then what are you doing with the harvest site? What are some of your go-to ways to get that to heal?
Yeah, the harvest site or the donor site, I you can try and suture up a lot of it, and then you could split thin skin graft it right away.
Mm-hmm.
In a healthy patient, that'll be fine because when you take off the fascia, you're looking at muscle. So if you put a skin graft over muscle, usually it just takes right away. It just looks kind of sometimes it'll look weird or it'll adhere to the muscle, so it looks like a crater is left out of their calf
Mm-hmm.
at the harvest site. But what in a lot of my patients, they're diabetic, microvascular disease. I don't want a skin graft right away, so I put some kind of scaffold graft, like usually Integra is my go-to. I'll just put Integra at the donor site,
Hmm.
let that heal in secondarily, and just let it heal in on its own, or skin graft it a month later.
Do you find any need for or any benefit of wound vac for that, or no?
Not really. You don't. I don't. The muscle is nice and vascular. I don't need it to. It's not that deep of a hole to need to wound vac to fill in.
Yeah.
It's flat enough to accept the scaffold graft. So, and just for simplicity, I don't want it having to deal with 3 times a week dressing changes on a recipient site when there's a complicated flap
Hmm.
adjacent to it. Although sometimes I do wound vac over the flap.
Yeah.
That's pretty common too. But I try and avoid wound vacs if possible
In general or in flaps?
in general.
Just because of the nature of having to change them so often and the
Yeah, I
maintenance
mean
that comes
the
along with them?
yeah, I mean the literature will never tell you that it's gonna lead to increased infection rates, but like the sponge isn't. There's no antimicrobial bacteria. Sure, you could use a silver sponge, but
Hmm.
the standard dressing is a black foam,
Right.
and we're putting it in with like the gloves that are
Yeah.
you just grab it off the shelf and
Non-sterile
stick it in
gloves.
there, and
Yeah.
who knows like what if you get a leak, like what else is going to leak into that place,
Hmm.
into the area. The patients don't really like it. I mean, I'll still use it, but I try to do different ways of get granulation aside that wound vac.
Sure. How often are you using? I don't know if I can say it's my podcast. I can do whatever I want. How often are you using Santal to for enzymatic debridement of wounds? Do you use that
Oh,
often or no?
once a year on very
Once a
special
year
patients, but I
because it's
really
so
don't use
expensive,
it.
or you don't think it's very helpful?
Like it just doesn't fit into my treatment algorithm.
Yeah.
Like if it's like when do you really need Santo for debridement? It's either you cut it out or you just let it slough off naturally. I don't think
Hmm.
it actually debrides anything.
Hmm.
Um, I was trained using a lot of Santal, but I felt like a good operative debridement can eliminate the need to deal with that.
Hmm. Are you using mostly sharp debridement when you're in there? Do you use Versajet or sharp debridement, or what do you use?
Yeah, I use Versagest's great for big venous leg ulcers where you have a massive flat surface area to just sweep through. That's great for that.
Yeah.
Otherwise, just simple scalpel rongers, curettes will do the job.
Hmm.
Um,
You're
I,
essentially, and again, anyone listening, but I'm learning lots too. You're just cutting anything out that doesn't look healthy and viable, essentially, right? Just cutting out the
yeah,
bad, leaving the good behind, and then we'll figure out a way to get more good to grow later, whether it's skin grafts
hmm
or flaps or whatever it may be. But you're just basically
yeah,
removing anything that's non-viable or dead or
yep,
infected.
yep. And like I can see how like people used to do Santo for fibrotic wounds
Hmm.
that are too painful to debride, or you're scared to debride because there's like maybe a vein or something next to it, or you don't want bone exposed.
Right.
But honestly, like it's betadine is cleaner. I would rather that thing be clean and slow than to be infected and back in the hospital for amputation.
Hmm.
So I would prioritize keeping chronic wounds clean over perfecting the wound care regimen.
Sure.
And as we know, infections are catastrophic, whereas fine tuning the wound care regimen might get you an extra millimeter of healing over the course of a few months, which,
Hmm.
at the end of the day, probably doesn't matter a whole lot.
Sure. I want to talk about your project, Foot and Ankle Surgery Academy. For those who don't know or aren't aware of it, can you talk about what Foot and Ankle Surgery Academy is?
Yeah, it's a online video library where I have filmed my own surgeries and my colleagues' surgeries, and then we do our own narration to talk about what we're doing and thinking at each important step, and then we edit it into a nice little package where it's a video. There's like 100 videos of surgeries that we've done. It's a monthly subscription, um, and it's available for anyone. We found that students, residents, attendings, and even reps for foot and ankle hardware companies have found it useful
Hmm.
because we talk in we try not to get too deep and dirty into the kind of acronyms for everything. We just talk amongst each other as colleagues in a way that anybody could understand.
Hmm.
And we kind of started doing that because of the pandemic, where they shut down elective surgeries, and we're like, oh, well, if there's no elective surgeries, the next generation of podiatrists are not exposed to it. So where are they going to get that exposure and the training? So
Right.
that's what got us to start filming it. Plus, I felt like there's no really good videos out there. I mean, I've even seen videos of companies doing professional filming on a cadaver where there's no sterile field. Why not bring the camera and get right up in there and kind of see what the person's actually doing?
Mm-hmm.
They're not even doing that on cadavers. So
Right.
I took it upon myself to figure out how to do the filming, get the video right up in there so I can get the camera right up in there so I can see exactly what the doc is doing.
Yeah.
And I'm not afraid to ask my colleagues to move out of the way so I can get a good shot of the pathology because the
Yeah.
viewer needs to see it.
Right. It makes a big difference. So if people are interested in that, how would they get access to that?
Yeah, go to footandanklesurgeryacademy.com and then click on one of the subscriptions and you get access right away immediately. That's
Awesome.
it. Yeah.
And you're on Instagram. You're always posting interesting cases. Your Instagram handle, I know it's your name, but what's the full Instagram handle?
Yeah, limb salvage surgeon.
Okay. And
That's my IG handle.
they
If
can
you're interested.
find you that way or search your name. And then Foot and Ankle Surgery Academy also has an Instagram account that you can follow and get some little snippets and get an idea of what those videos are like. So I think that's fantastic. I think that's a great resources for anybody of any age who wants to kind of see and understand. It's one thing to learn it in class, but it's another to actually see it. And it's so helpful to see that before maybe they go scrub a case in residency or wherever it may be. So I think that's a fantastic resource for people.
Yeah, I've been surprised to hear how students used it to study, and then they use it to help with residency prep. And then they'll cancel, and then they're out in practice, and they'll think, oh, like they're about to do their own first bunion in a while or whatever. Then they end up resubscribing again to pick up tips that they've never picked up on before.
Mm-hmm.
So it's just fascinating. Like when you watch someone operate, like I'm sure you've as a student, when we're watching someone operate, you don't pick up on those little nuances that you would as an attending. So it's worth rewatching. That's why we call it a library, because it's something, it's a resource you can use over and over again.
Sure.
And I've even found myself going over the videos that I've edited before, because I'll be like, wait, how does that section go? How did Dr. Haas do it or Dr. Cobb do it? I need to review this one more time.
Yeah, for sure.
So
that's
it's
awesome.
even helpful for me. Yeah.
That's great. Well, thank you for joining me tonight. I appreciate it. This has been really interesting and informative. So thanks for hopping on.
Yeah, thanks for having me.
Absolutely.
Yeah.
So Limb Salvage Surgeon on Instagram. Check it out. Always posting interesting cases. Thank you, everyone, for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.